Hello, everyone. Welcome to the Pfizer-supported series of online symposia. I'm Dr. Evelyn Ho, and today both myself and Dr. Pat Gomez will be speaking on two topics related to breast cancer. Okay, so today we are going to talk about myths, which are fake news, falsehoods, pseudo facts, and the reason I'm showing this is because the color has a lot of pink in it. And it also shows that a lot of things that we can see may be all due to perception. Is it there or is it not there? So I would like all of you to look at the picture on your left side. Do you see a man or do you see a woman? Do you see this woman or do you see a man with a big nose? And in the middle picture, do you see a young lady or do you see an old lady? So here is the chin of the young lady, or it could be the nose of the old lady wearing a big fur coat. And how about this? Are the lines horizontal, straight, or are they crooked? Look at all these lines. Are they straight or are they crooked? And finally, do you see black dots or white dots at the intersection of the lines? All these, are they white or are they black? So your eyes are actually playing tricks on you, and you can see as if some of them are black and they are flashing at you. I hope you can appreciate what I mean by perception is something that you see, and it's not, in a way, it's not false because that's the way your brain and eyesight is processing it. So in today's world, I think all of us are bombarded with a lot of social media and we Google a lot. And what's happening is that we ask friends and we ask relatives a lot. But for some reason, I think the trust level when we ask doctors, sometimes we trust a lot, but often we may not trust the recommendations from the doctors. So it is very important for you to choose what we read and listen to, because I'm addressing the myths. If you read and listen to the right things, you will be able to make decisions based on good, correct facts. So these are examples in which you may actually read something which is totally wrong, but because you're biased, your brain is thinking in one way and you're biased to something, the cartoon shows that. How do you know if a news story is true? If I agree with it. So it is not a joke actually, because it is exactly what happens, and biases happen to all people. It also happens to me. So you have to be aware that you have all these things playing around in your psyche that results in you falling prey or even listening to wrong facts thinking that it's right. So there's such a thing as it's logical, but actually it's not true. You have this cognitive bias. That means you tend to believe, for example, if you're very conservative, you don't like to operate, you don't like to have any biopsies, then a doctor who tells you no need biopsy, no need operation is who you will listen to, or a alternative medicine or complementary medicine doctor. Don't forget, a lot of people listen to individual testimonies and they think that that one person who succeeded in having whatever they had is representative of the million people out there. Actually, it may not be. And of course, I can have true facts, but I spin it. And I think on COVID-19, you have seen how facts are spun to and fro until you're not sure whether you can drink warm water and it's going to cure COVID-19. Now, breast is a very emotional disease, an emotional organ, I would like to call it. And once we have fear, we tend to ignore evidence. If we feel risk, we don't think about risk, we feel it, okay? These are things which we need to be aware of. And we are easily influenced, especially if we have somebody whom we respect. For example, if it is my elder sister, it could be my teacher, it could be my friend. And that's why you have so many social influencers online, which actually influences what you watch, what you wear, what you eat. And remember, these perceptions that I showed you just now is also partly emotional, and we tend to avoid rather than we want to regret something that happens. So these are the factors that are in play, why we are who we are and why we believe the myths that are being propagated nonstop. Now, one of the questions that Ranjit or BCWA gave me was that if finding a lump in your breast is equal to cancer. Now, only 1 out of 10 may actually be a breast cancer. And the younger you are, the less likely it's going to be a breast cancer. So this one definitely is a pangka, okay? You do not get any marks for saying that if I have a lump in my breast, it's cancer. And I will explain a little bit more about this. Very often in your breast, you feel lumps, or you feel like as if there are many, many lumps. And I would like to use the word lumpiness as the texture here. So The problem is your breast is not evenly textured. There may be parts of it which are more firm, other parts which are softer. So if you go soft, firm, you tend to feel what is known as lumpiness. So the ability for you to feel something in your breast really depends on where it is growing. Is the growth close to your skin, or is it close to your chest wall muscle and your ribs? Is it hard? Is it soft? And then what is your natural breast texture? Some people I have felt really, really firm breasts. Others may be soft, but almost never it is going to be even textured like the hufa. That means it's not going to be soft, it's not going to be evenly textured. There's always something in it because you do have glands, fibrous tissue, you have fat, and then you have blood vessels, and you have, some people have a lot more fibrous tissue, some people a lot more fat. So the size of the breast also does not determine what you feel. Therefore, what you feel depends on whether your surrounding is harder, softer than what it is. So if you have a very firm breast, to be able to feel a nodule or a growth, it has to be close to your skin, or it has to be harder than your natural firmness. So this is why once you feel something in your breast, almost always, if you're very, very young, it's not going to be a cancer. As we grow older, of course, the facts will change because the risk of cancer increases, especially if it's something new and you are 70 years old and you suddenly feel something. Now, why women may think they do not need a mammogram. So these are the things that come up. Oh, I do self-breast exam. I'm very good at self-breast. I do it very carefully. Or I go for clinical breast exam, maybe with Dr. Pat. Maybe you see your GP. Maybe you see your female gynae. Or the other group thinks ultrasound is good enough. So the answer is to self-breast and clinical. It all depends on your age group. Ultrasound being good enough for screening, meaning if you have nothing wrong with your breast, then that answer is totally erroneous as well. It's not going to be correct. So if you are young and you do self-breast, that is all you need. All right. When you are young, you do not need a mammogram. And I say young is anybody less than 40 or less than 35. If you go for clinical breast examination, again, it depends on your age group. Once you reach old enough and breast cancer is common enough in your country, such as in Malaysia, it starts to rise after 35 and after 40 it goes higher, then of course you want to add a mammogram even if Dr. Pat says your clinical breast examination is normal. Why? Because a mammogram can feel things or can see things way before your hands can feel it, which means it's at its earliest stage. So the other reason why women don't think they need mammograms is the power of the media. Now, in 2010, 2011, thyroid cancer was said to be growing fast because of harmful effects of radiation from dental. Now, the dental X-ray is really tiny, right? And it's very low dose. And it seems for mammograms. Now, mammograms, have you ever noticed a mammogram machine being used to shoot an X-ray of your hip or your chest or your bones? It's impossible because the mammogram X-ray is really, really low dose because it has to differentiate between soft tissue of fat, glands, and fibrous tissue. There is impossible for it to use for anything more, which means it's a very light radiation dose. Secondly, thyroid cancer, yes, the number of cases seems to have increased because everybody's doing ultrasound, and then guidelines come out that are at a certain size you want to put in a needle and test. But they have found that the death rate from thyroid cancer, even though we are increasing the number of diagnoses, has not increased. So what does this mean? This is a very good sign that we are overdiagnosing thyroid cancer, we are overtreating thyroid cancer, which would not have become a problem for the patient. This is unlike breast cancer. In breast cancer, we are actually saving lives. So if the cases go up, you'll find that people are living longer if we catch it early. Now, if you go to a country where we are not catching cancer early, then it doesn't make a difference to, again, your lifespan. Unfortunately, people like Dr. Oz has already made its damage despite everything that we tried to refute. And it went crazy all over the world. And I see this being circulated on WhatsApp every now and then, even until today. So you can see how old news keeps recycling and just repackage it slightly different. So this is the fear that many people have. A mammogram will give me breast cancer. The radiation is dangerous. The compression will cause cancer to spread, and younger people cannot have mammograms. Okay, so unfortunately, all this is wrong, and let me explain why. The compression in the mammogram in the first place is even so that you can reduce the dose that is given to the breast. You need it even textured, even thickness, and also it lowers the radiation dose and it prevents the breast from wobbling about. Now, the wobble in the breast is what makes ultrasound, the way we do freehand ultrasound, inaccurate sometimes. The bigger the breast, the more it will wobble. It's impossible to make the breast stay still because there are no two bones to hold left side of the breast to the right side of each breast, okay? And the fact that younger people cannot have mammograms is also wrong because, number one, we do not do screening mammograms in the young when cancer is not common. And number two, if I suspect cancer in a 19-year-old, I will definitely send her for mammogram to get a better overview of the whole situation. And I will illustrate with my final case at the end for example showing. So, and no one has ever been able to prove that a mammogram caused the breast cancer. I have had many women told me that, oh no, because of the mammogram, I got breast cancer. I said, no, you had the mammogram and you found your cancer way before you could feel it. It's the other way around, not that it caused your cancer, but it found your cancer. So the other thing is, I'm going to help you put radiation fear into perspective. For example, here, every single one of us per kilogram, we are emitting radioactivity. BQ stands for becquerel, which is the measure of radioactivity. So the heavier you are, the more radioactivity you're emanating out. The more people you have in a room, the higher the radioactivity in that room to each other. Okay? You like coffee? Well, I'm going to let you know 1 kilogram of coffee is 1,000 becquerels. In fact, even the milk that you drink, because the carbon is in carbon 12, 13, 12 and 14 isotopes. Some of the isotopes of the carbon atom are radioactive in very, very small amounts. It's not going to kill you. And finally, those of you who says, okay, I'm avoiding crowds, I do not drink coffee, then sitting right now, if you have a granite top or even you have any bricks, if you are up in some highland right now, like Cameron Highlands, you're at higher risk of radiation because you're closer to the sun, the cosmic radiation is higher. Whenever you sit down, there is radiation all around you. You cannot avoid any radiation. So what am I trying to tell you? Every day of your life, you have natural background radiation. So the next slide I'm going to show you is going to compare the mammogram effect related to your natural background radiation. Of course, these figures are for the average space in USA. You find that if you live in Denver, which is about 6,000 meters up, or is it feet up, you'll find that your radiation dose is higher. So if you have only a simple 4-view mammogram, then the risk of that mammogram is equivalent to smoking 1/8 of a cigarette. I can guarantee you throughout your lifetime, you have smoked more secondhand smoke than anybody else. And some of you may even be ex-smokers or still smoke. I have patients who smoke but come regularly for their checkup. If you like traveling, of course, now we can't, 70 miles by air, that's the equivalence of 1 mammogram. Traveling 10 miles by car or simply just sitting here for 3 minutes because anything can happen to me. Something can drop on my head, and it has happened before. So if you look at the mammography, it is there's another, this one is the millisievert. There's a dose received rather than the radioactivity given. So the word is MSV is millisievert, and it's equivalent to about only 7 weeks of natural background radiation. Now compare that with a PET-CT, which is 8 years of natural background radiation concentrated into that time in which you do your PET-CT. So for those of you who need PET-CT regularly, make sure that it is justified. It's definitely going to change your management, and find out if you can do something in between the PET-CTs. Now, in many centers all over the world, they actually have very strict guidelines on when they do PET-CT, and they don't do it unnecessarily. And they have a way of recording amount radiation, number of PET-CTs you have, or other CTs you have, or maybe radiation treatment. They are measuring and watching their cumulative dose, because that kind of 8 years concentrated into one examination, that is going to make a great difference to mortality, your death rate. There is a theoretical risk. Again, everything is theoretical because it's extrapolated from the atomic bomb that happened in Hiroshima, in the something that happened in history. And that's how all these calculations come from. So the next myth I'm going to go through is men don't get breast cancer. So men don't have to worry about it. And I'm going to play you something from something that I heard when I first started out educating people about breast. And so obviously this is wrong. and I'm going to play it. And it's a 1999 BBC recording, and I just accidentally happened in the old days. It's the old-fashioned, cassette tape with the radio.
If you're a man, you might be listening with some concern for a loved one, your wife or friend or even a relative. But I doubt you'd be thinking much about your own risks of breast cancer. The risks are very small. Male breast cancer is rare. But the story of Michael Beckman, a prominent lawyer in London, might just change your attitude. Michael is being treated for breast cancer at the moment. So as it stands at the moment, how would you propose to change things if you had a chance?
Well, what I think is absolutely disgusting is this constant harping upon the fact that it is only a woman's disorder. That is absolutely, completely wrong. And all the advertising, and I gather this is worldwide, all the advertising concentrates and talks about women and their breasts and breast cancer, should completely cease. It should be changed totally to people can get breast cancer, and it may well be far more frequent in women, but it can also be dangerous in men.
On a practical level, apart from the advertising and getting the messages across, what would you say to someone who'd perhaps found a lump, but because they were a man, were prepared to just let it go and forget about it?
Well, they shouldn't do that unless they want to take the risk of getting cancer and having all the problems related to cancer, including death.
Okay, I'm coming back to the previous one. So because of that, ever since 1999, this struck me really hard that all the messages tends to be focused on women, and men who get breast lumps ignore it. And so they go late to see the doctor. I'm happy to know that sometimes it's the wives who bring their husbands in because they felt some lump in the husband's breast. But it's important to know that men also get breast cancer, and I will also address another part of their family history, which impacts both female and women. So let's go on to the men and women. So this next myth is my mother never had breast cancer, so I don't have to worry about it. In other words, you are saying I have no family history. Wrong. Why? The main risk factor for breast cancer is being a woman. So it doesn't matter whether you are eating very healthy, or you are exercising plenty, or that you have no family history, or that you had your first child before 30, you breastfed all your children for a year, all of your children were before 30 years of age. I don't smoke, you don't drink a lot of alcohol. It doesn't matter. As long as a woman, you are at risk for breast cancer. Just look at the age-specific incidence rate shown there. You will see that this is from the Malaysian National Cancer Registry Report 2012-2016. Look at how common breast cancer is in Malaysia. And these are only from those who are reported. And that you also see a tiny incidence of male cancer. It can be 0.5 to 1% in the population, depending on which country you're in. It may even go up to 5%. And look at how far breast cancer is ahead of colorectal cancer, even in men, or cervix or ovarian cancer in women. So since more women tend to think that the pap smear is more important, this shows you how important it is that we need to detect breast cancer early, because in terms of a disease burden, breast cancer is way higher than cervix or ovary. So these are some ethnic variations. Chinese more than Indians, more than Malays. And of course, we are very low compared to USA, but we are still high enough to be a disease burden. Right. Now, just some words about what do we do for early detection. We do not use ultrasound for screening. No, 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 no. Okay, don't think that it is able to do that. We may have certain specific women in certain specific conditions where a mammogram is impossible, and then we might do an ultrasound, or almost always the ultrasound is done after a mammogram. Now, if you are, of course, young, less than 35 years of age, where the risk of cancer is lower and the chances that of you having a breast cyst, a breast fibroadenoma is higher, then we always start with the ultrasound, unless say your breast surgeon or your GP feels that say, oh, this looks highly suspicious, then we may start with the mammogram. Now, you need to know that if you're young, don't send all your daughters for ultrasound, please, because if we find a tiny cyst or a fibroadenoma, then your daughter will no longer be insurable for the breast. They will reject the breast. Okay, so It doesn't matter how young they are. It doesn't matter how benign it is. The chances are very, very high now that they will not insure you, or your medical insurance will exclude anything related to the breast, and your life critical illness may also not connect with anything related to the breast. Now, MRI in Malaysia is used very judiciously for many reasons. It is, number one, with biopsy facilities are not widely available. We have lots of MRI all over the country for your backache, for your headaches, even for brain, but definitely with biopsy facilities. You do MRI breast, even if you have a center that does MRI breast, but is unable to biopsy it, and that lesion cannot be seen on ultrasound, cannot be seen on mammogram, then you are stuck. So you need MRI. If you do MRI breast, it used to be said without biopsy facility, please do not provide that service. Secondly, it is at least 10 times the cost of your ultrasound. And there's concern about gadolinium. Now, gadolinium is not like the iodinated contrast media you get in CT scans that you use in angiograms. We have used that for many, many decades, and it's relatively safe, although there's still a tiny risk. In the case of gadolinium, although right now we are only more concerned with people who have severe renal or kidney problems, you find that gadolinium is a toxic metal chelated to something that is injected to our body. And they have found out that gadolinium actually accumulates in certain parts of your brain, in your bone. And recently, the rat study showed that it actually affects your peripheral nerves. Okay, so in other words, we are still not sure what is the long-term effect of gadolinium. So the recommendation from Europe is to not use gadolinium unless you can not help it. In other words, you have something that is going to change the management, save your life, then of course we do the MRI with gadolinium. Now I need to tell you that screening MRI breast must be done with gadolinium, otherwise you're wasting your time. All right, so you have to use gadolinium if you're screening for cancers in MRI, because lately there are a lot of women, young women, who think that, oh, it's safer to do MRI because my breast is dense, and but you forgot you need to use gadolinium. So we do not know the outcome. We are still watching that space. They are trying to develop MRI which does not use gadolinium and see whether it's useful in picking up cancers. Having said all that, the third edition of the Clinical Practice Guidelines for Management of Breast Cancer Malaysia 2019 just say that for those 30 to 49 years of age, they do recommend annual MRI with mammograms together. You cannot do just the MRI. With mammograms are recommended for very high-risk women, the BRCA 1 and 2 carriers. So don't forget, digital tomosynthesis, which the layman calls 3D mammo, is actually gaining a lot more centers are converting their machines or changing their machines into this more expensive tool, but it is definitely more helpful to reduce and improve our ability to be sure that you don't see something abnormal. And finally, the game changer and the alternative to MRI is really contrast-enhanced mammogram. I do not have the time to talk about it, but here are some images of where a normal mammogram is seen, that is the medial lateral view, MLO, the side view. And look at how the lesion pops up. And usually significant lesions will pop up. Sometimes you have DCIS, small calcification, you're not sure. You just put contrast, and it's the same contrast you use for CT scanner. And it is about 1/3 the cost of MR, depending on where you are. If they don't charge you for the big, huge syringes which are required and the injector, then the price may actually go down. So it's basically a mammogram, so it's very fast. It's relatively safe because we know iodine contrast medium has been used all over the place. We do know that lots of people are having angiograms with it, and and most of them are fine. Okay, so this might be a game changer. It's beginning to gain traction. GHKL does this. Now, then this one is, if I have BRCA, I'm definitely going to get breast cancer. All right. So is genetic testing the answer or not? Now we know that in a general population such as USA, 12% will get breast cancer. And in a recent study they did, 72% with BRCA1 mutation and 69% with BRCA2 will develop cancer by the age of 80 years. That is what they mean by your lifetime. And in Malaysia, the lifetime is up to 75 years. That's the average lifespan of female. So this one, maybe genetic testing is an answer for some people, but it may not be, and I will show you why. Now, because of Angelina Jolie in 2013 going to tell everybody about it and appearing in Time magazine, in fact, that's her on the cover of 2013, there is increased awareness and increased interest. And Angelina Jolie is an influencer. Look at her, she's still around on the cover in Elle in 2019. The danger is many women have fallen prey to direct-to-consumer online marketing and tests. Now, you need to know that you need proper counseling pre and post-test to find out what does your meaning of your test. What is the meaning of the results of your test? And it's not BRCA1 and 2. Sometimes they do panels which include other types of mutations that predispose you to cancers, not just breast cancer, but cancers. And I think I addressed that in one of my talks earlier in May. So what are the barriers to testing other than the fact that it's very expensive? It actually impacts marriageability. And this has come from my patient from a certain ethnic group, where if the whole family knows that you are BRCA positive and your daughter runs a 50% risk. Now remember, if a mother or a father is BRCA positive, the child has a 50% risk of carrying the BRCA gene as well. And even if her second copy of genes is normal, she will carry this BRCA mutation, and it will impact her marriageability in the sense that if she carries that mutation, then she may develop a cancer according to that percentage that I showed you earlier. Not that she will 100% develop it. The other thing is you have insurability issues, you have employability implications, because in Malaysia there is no law to prevent employers from discriminating against people who are high risk. So now if you look at COVID-19 situation, companies are struggling to even keep their staff. So obviously, if you have any of this, don't be surprised that if you're let off. The other thing is your family members, could be your sister, could be your cousin, may not want to know. So if you do this test, you need to decide whether your family members need to know about it. And if they need to know about it, they need to be aware that they may not want to know about it actually. Basically, is they don't want to know about it. And I just told you, the highest risk factor is being a woman. Just because you don't have BRCA doesn't mean you're not going to get breast cancer, because the majority of women who get breast cancer don't have BRCA positive genetic mutations. The other thing is that it's, like I said, not widely available to genetic clinic. You may be able to get the test, but who's going to explain what is the implication to you? Of course, Cancer Research Malaysia is our first Asian national network for genetic counseling for inherited predisposition, but they cannot cope. It is free at the moment, the counseling, because they are a foundation which is tax exempt. But, and of course, University Malaya, and I think in a few other major centers, and maybe even in Pantai Pet will let you know, may have genetic counseling. And you need very good genetic counseling so that you are aware, and when you do your test, you know what you're going in for. So don't be surprised if all these things happen and your family members may not want to talk to you. So this has happened before, and these are the things to consider before you decide, hey, let me go and get a BRCA test. It's not like just going to get your blood test to see whether you're diabetic or not. It's quite a different ballgame. Just like HIV testing, we still need to maintain privacy because of a lot of implications from it. Okay, I will just finalize this whole short talk by showing you an example of my patient from 2005, who is a 29-year-old Chinese lady who had a palpable left breast lump. She complained of a left breast lump. The surgeon felt it. Of course, at 29 years, ultrasound was done first, and then subsequently, the surgeon excised the palpable lump. She did not do a needle biopsy first. Now, these things were all done before she saw me, so I cannot explain to you why, but I can suspect that perhaps the surgeon felt that maybe the needle biopsy may not be good enough based on what was seen on that ultrasound. So 2 weeks later, was referred to one of our breast surgeons, and look at that. So these are her mammograms. She's 29 years old. We did the mammogram, and you look at the calcifications that tell us that she has widespread DCIS, precancer, in the left breast. And on the right side, you saw a little circle, which actually has a very tiny cluster, which was slightly suspicious. So would MRI have helped at this stage? No, because we already know from mammogram she has multifocal DCIS. Let's just assume that we did not see this. Then the alternative to MRI, because it's so expensive and it's not widely available, would be the contrast enhanced mammogram in today's setting. So in a lot of countries, even in the US, the contrast enhanced mammogram has become taken up in some centers, and nobody looks back. None of the surgeons now look backwards and say, oh, we need an MRI. There are, of course, certain situations where an MRI is still needed. But in Malaysia, many times we make do with the mammo and the ultrasound. And then at this point in time, genetic was at a fledgling, like baby germinating your plant. So at that time, the genetic clinic was almost very non-existent. You have it a lot in children, but not so much here. So anyway, so the decision was to remove her left breast, do a reconstruction, and because she had a slightly suspicious cluster on her right, we did 6 monthly mammograms, and the decision was made that every year she will make sure that both sides are mammo. I will show you why. So this is her 15-year follow-up, all right? So 2 years later, unfortunately, this is her reconstructed breast. These are the mammograms of reconstructed breast. 1 year later, and pum, the next year, here is her cluster of calcifications, and in fact, it could be felt if you really look for it. So again, she had DCIS as well as invasive ductal carcinoma, and she was treated. They did not remove the breast or reconstruct it again. They just removed the area of concern. And then in the 3rd year after her initial diagnosis, her right side calcifications increased, had a biopsy, confirmed it was DCIS again, and she did a mastectomy and recon. So at the age of 32, she already has no breast anymore. She has bilateral mastectomy, all right? And both are reconstructed breasts. She had a recurrence already on the left side. Okay, 7 years later, she did a BRCA testing and she was BRCA2 positive. All right. So again, you know, she's just followed up. And then 10 and 11 years later, she ended tamoxifen. She wanted a family and she managed to have a son. And it's a very happy family and a very beautiful family. I have seen them. And 1 year after that, because she was BRCA2 positive, she decided to remove her ovaries and uterus. So she has removed the organs which are most commonly associated. Now, BRCA1 and BRCA2 are associated with other cancers, by the way, but we have no time to talk about it. Now, 15 years later to this year, she was found to have something in the right, near the right armpit. And yes, the biopsy showed that it was positive for cancer now, and they are going to do a wide excision, and then she's going to undergo chemo and radiotherapy. So you can see what are the facts I want to show you in this story, which is a true story. Number one, mammograms can be used for follow-up, even for reconstructed breast in some select patients. And then you cannot say now that mammogram caused the cancer, right? Because there are no more breasts in her, and yet she still develops cancer. And we know that people who are BRCA positive will explain the one that she developed right cancer after the left cancer, or it could be she may have had the cancer at the same time. But imagine if you are 29 years old, and I'm telling you I'm going to remove one of your breasts, and you haven't proven cancer in the other breast, or you can't accept that so many things are going to happen to you, would you be willing to remove both breasts prophylactically? And one of this example also shows you that removing your breast just because you're BRCA positive does not mean you will not get breast cancer. In other words, Angelina Jolie actually has maybe a 1 to 5% chance of still getting breast cancer, because even in a mastectomy, you cannot remove every single cell off the chest wall. So these are the facts that you need to know, that even if you're BRCA positive, what are you going to do about it? Are you accepting it? I have women with breast cancer who refuse to operate. And now before you develop breast cancer, you're telling me remove both my breasts? So not everyone is going to accept that. So I have no time to talk about BRCA or genetics, but this is a very good site from www.cancer.gov. You can Google it. The fact sheet there, one by one, is all explained in layman terms, exactly what it means, what are the genetic tests, what is it, what are my implications, you know, and how it affects your risk, and what other cancers are associated with BRCA. So my final take-home messages is this: what is meant for imaging, because I am basically a radiologist and I'm an imager, that if you're 50 to 75 years of age, even if you're perfectly fine, consider a mammogram every 2 years. If you're 40 to 49, talk to your doctor. Consider a regular mammogram every 1 to 2 years. And why do you say 1 to 2 years? Because we find that cancers grow faster as when you are younger. And finally, if you're more than 35 years old and you come in with a problem in your breast, we will probably start with a mammogram as much as possible before the ultrasound. Why? The mammogram serves as my GPS. What does it mean? It's like my Waze. It tells me where to look. It may direct me to some place. Yes, you may have dense breasts, but all dense breasts are not the same. And today we have no time to talk about breast density. Is that not all dense breasts are the same, and we can still see things. Don't forget, we do 3D a lot now. So we peel off each layer of your breast like an onion to be able to see what's going on. And of course, if you're very much younger, less than 35, and you come in with a lump, PET sends somebody with a lump, or she feels something wrong, it always starts with an ultrasound, unless the breast surgeon or the doctor tells me, hey, this looks really, really suspicious, then we will start, even if you're 30, start with a mammogram. Because again, the mammogram is my GPS, my Waze. So if you feel anything might not be right at all with your breast, and all of these things, mammogram, ultrasound doesn't appeal to you, you are anti all these examination, then whenever you feel nothing is right with your breast or something is wrong, please go and get it checked it out. See your doctor. In other words, when you feel something is wrong, don't wait. Go see your doctor. Okay, that is the end of my talk. And thank you. We have a lady who asked about calcifications in her breast. So for the benefit of everyone, I typed the answer to her. Calcifications in the breast are very common. So what we're looking for is the pattern, which is why the mammogram is the only one which can show you the pattern. And most calcifications are not cancer. That's the good news, right? But the pattern that we need makes, therefore, your old mammograms extremely important. The more old mammograms you have, the better it is for comparing it. Now, each mammogram you do, I know some ladies will do one in Center A, another year in Center B. Sometimes you go where all the promotions are, where it's cheapest. And then sometimes you don't even get any mammogram back. If you're lucky, you can get a CD. You find that the comparison is not the same. And sometimes what could not be seen on 1 year's mammogram could have been seen 3 years ago. So all these mammograms will help you to determine whether it's safe or not.
Recently, I have a lot of lymph nodes.
Mm-hmm.
Okay, so because I did once at a cancer society, they said a bit suspicious.
Mm-hmm.
So, but when I moved back to Kota Kinabalu actually, then
Right.
when the doctor did, they tried to take the sample, but they couldn't get it.
Right.
Yeah, so it's a bit like, now that I feel it's more,
Okay, so if it's big enough, sooner or later they should be able to aspirate, and you can't easily come back to KL because of all the
right, yeah.
MCOs. So you should be able to get if it is suspicious. And is it on the same side as your cancer or opposite side?
Actually, I don't have cancer, but I have a 3 surgery to remove lump.
Oh,
I have big lumps, yeah.
Okay. In that case, do not get panicky because the surgery that removed the lumps, was it suspicious kind of cell?
It's not suspicious.
It is not the atypical cells, in other words.
Yeah, that's right.
Okay, so then you shouldn't have to worry because very often, ketiak, where we have our hairs and all that, plus the fact that sometimes we have, like now, for example, with the hand sanitizer, alcohol, I have such dry hands, even though I use so much cream, it's cracking.
Yes.
So I can expect that, this will cause my lymph nodes to also swell a little bit because it's reacting to the inflammation.
Okay, all right.
Okay, so sometimes your lymph nodes are due to that. If you have eczema, then you tend to have big lymph nodes also.
All right, sure. Thank you, doctor.
So just need to monitor, all right?
All right, yeah, I will. Thank you so much.
DEXA scan on Arimidex. Okay, let me tell you something about the DEXA scan, Pei Hun. The DEXA scan looks for bone mineral density, and it's best that you do it in the same center and no earlier than 2 years apart. Why? Because there is a error margin for the reading for DEXA, which is anything from 5 to 10%. So if you have a minimal increase or reduction in your bone mineral density, it's basically unchanged, all right? The DEXA, your bone mineral density is unchanged. So if you do it too soon, you're not going to be able to look at that difference because there is an error in measurement during DEXA.
Hi, Dr. Evelyn.
Yes.
I want to inquire about the radiation dose between PET and CT. Because after a cancer, after finishing all the treatments and so on, the oncologist will send you to do either a CT or a PET.
I would just do a plain CT usually because breast cancer is not like certain other cancers, okay? Because a PET CT doubles the dose.
Oh, I see.
It's basically doubles the dose. Because normally in a CT scan, we give contrast so that we can see the different organs being highlighted plus the blood vessels. Right? At CT, in many places, they only do the radioactive dose and not the contrast dose, which is why sometimes after PET CT, you still do CT, which is a lot of those. Yeah. So it is actually not recommended as routine, especially if you have early stage cancer. All right, to do a CT scan even for staging. So if you look at the guidelines, it doesn't say so. But of course, every single person is different. So you need to take this up with your doctor and ask why. Is it that will the harm be more than the benefit? Yes. So I am very careful about asking people to do CT scans. But if you tell me I did my mammogram 2 years ago and you are 60 years old, I say go ahead and do it. You see the difference? I do a mammogram nearly every year, but now I've delayed it to 2 yearly. Okay, because I'm already, coming to the age group where I hope things don't grow so fast. But at the end of the day, if you have had breast cancer, it's a different story. You need to do it every year, preferably. But I have patients who have more than 10 years of cancer, and some of them are not coming every year. And then there's the other group, after 20 years of having breast cancer, still faithfully come every year because they feel better that they do something to tell them what's going on.
You mean every year, meaning coming back for CT
No, for cancer, for breast, for mammogram. I'm not talking about CT.
Okay.
Yeah, I'm not talking about CT. I'm talking about mammograms. So the low dose in the mammogram is so different from. See, imagine 7 weeks of background versus 8 years each time you do. So that is it's not exactly the same, right? So if you're a very big person, you have giant sized breast, you have extremely dense breast, the dose has to be higher. So we are talking about the average breast, which is 50% glands, 50% fat. All right. Okay. So these are all guidelines only. So please do not go and tell your doctor, oh, Dr. Evelyn said cannot do. I don't say that, please. Discuss with them. I said, I've stage 1 cancer. Do I really need to do a PET CT according to the guidelines I read? Basically is to educate the person so that they ask the correct questions. So you may have high risk factors why they may want to do it. Maybe certain features of your cancer or whatever is such they worry.
Okay, great. Thank you so much.
So I have no more breast and did not do breast reconstruction. There's no need for yearly mammogram. What do I do then? This is where you use your hands free of charge and you use your eyes, okay? Look at your breast, feel it, your chest wall or your scars. Feel yourself, feel your armpit, okay? Feel your neck, go see your surgeon once a year. Okay, I do not know how many years post-op you are, but these are the things you can do. Yes, you do not need anything specific, but at any time you feel something in your scar, something in your armpit, then of course we start with the ultrasound. How effective is it in increasing the level of calcium?
It doesn't really increase your level of calcium. What it does is take away take the calcium from your blood and put it into the bones. Okay, so when you take calcium orally, what actually happens is the vitamin D that you take it with usually will help to get the calcium absorbed from the intestine. And then once it's in the blood, Prolia takes it and puts it in the bone. That's how it's supposed to act. So it's like different levels of action for different things. So Prolia is actually very good for women who are osteopenic or osteoporotic, to help to maintain the bones so that you don't develop fractures and all the rest of it. Because the side effect of the hormone treatments that you're on will actually cause osteoporosis.
Okay, thank you, Pat. So we are here on an online symposium, and our second speaker is Pat Gomez. Take it away, Pat.
So basically, we're going to talk about a little bit about the breast cancer and a little bit about diagnosis and a lot about the treatments. Okay, can I have the next slide, please? Okay, so that's what we're going to talk about today, diagnosis and treatment. And of course, if you all have questions in between, you can either put it on the chat group or on the chat, or you can just let me know what you're thinking. Yeah, all right. Now, next slide, please. Okay, so breast cancer is the #1 cancer killer of women in Malaysia. It is the #1 cancer. It outstrips all other cancers by almost 2/3. And if you look at the incidence, okay, in the USA, breast cancer is about 1 in 8. 1 in 8 women in the US get breast cancer, and in Malaysia, it's 1 in 19. So it used to be about 1 in 30 in the 1960s and 70s. So of course, now of course Malaysia boleh. So we are slowly catching up with the West, yeah, and our incidence of breast cancer is increasing rapidly. Next, please. So what exactly is breast cancer? So if you look at the slide on there, that's a cut section of the breast. And when you look at the breast, you have milk glands, okay? Those are the milk glands. And each gland has a duct that opens up on the nipple, all right? So cancer actually comes from the lining of the ducts. Most of it anyway, at least 90% of breast cancer comes from the lining of the ducts. And because of that, okay, there is a process how it forms. So if you go from the top there, that's normal cell, and then as you slowly come down, it becomes atypical ductal hyperplasia, abnormal cells, then it becomes the pre-cancer, and then finally cancer. Cancer, you can see on the diagram right at the bottom, is when it is actually invaded or broken out of the duct and can spread to other places. Next slide, please. So what exactly are the symptoms of breast cancer and what tests are done to diagnose breast cancer? All right. Next slide, please. So most of the time, and the way that we would really like to find it is there were no symptoms at all. That means you're completely asymptomatic. You go for a screening mammogram and ultrasound, and then we find some microcalcification or a very small lump that cannot be felt. And that would be the best way to actually find the cancer. But most of the time, you'll find that it presents with a lump in the breast, okay? And the lump can either be in the breast or in the axilla or armpit. And that means, of course, that it has spread to the lymph glands underneath the arm. Some of the time when the cancer is quite large already, you can get nipple retraction. Nipple retraction is because of the cancer growing underneath the nipple. And because it's very hard and fibrotic, it tends to pull the nipple inside. And that's why you see nipple retraction. Very rarely, you can also get bloody nipple discharge. You get blood coming out of the nipple. That's a very good sign because the woman comes running immediately to see me. But it's not very often, okay? Basically, any changes to the normal breast needs to be examined and checked by a doctor. Now, I put pain right at the bottom there because pain is usually not a symptom of breast cancer, okay? Most of the time, pain occurs in less than 5% of breast cancer at presentation. Okay, so usually when the patient says pain, patient is very worried, but doctor is very happy because it's usually something that's hormonal, okay, and not really breast cancer. Next slide, please. Okay, this is a very rare form of cancer, and this is actually what we call Paget's disease of the nipple. And you find that actually the nipple gets destroyed. Okay, it starts off as a rash, okay, but the nipple slowly gets destroyed. Okay, and actually underneath that nipple there will be a lump or a hard mass that can be felt. Next slide, please. So what exactly? How do we investigate breast cancer? So, of course, the first thing is that the doctor will examine you, okay, and then probably send you for some imaging, as Dr. Evelyn already said, okay, it may be an ultrasound, it may be mammography, it may be both. Very rarely, we would also do an MRI, and this is basically to try and delineate what exactly is going on in the breast, and she's talked in detail about that. We will also do a biopsy. Now, a biopsy can either be a fine needle aspiration cytology, where they put a tiny needle into the lump just to get some cells. You need a very good cytopathologist, somebody who looks at these cells and then tells you whether it's cancer or not. Or most of the time, what we do is a core biopsy. Core biopsy means under local anesthetic, we take a little bit of the tissue from the lump and send it for checking. Sometimes, very rarely, we also excise the whole lump, okay? And most of the time here in private, we do guided biopsies. So that means, it'll be an ultrasound guided biopsy or a mammogram to guide the radiologist to pick up the calcium in the mammogram to send for checking. Please remember, there is no blood test for breast cancer, okay? The tumor markers that you find in the blood tests are not diagnostic of breast cancer, okay? You could be absolutely normal and your tumor markers could be raised, or vice versa. You could have cancer and your tumor markers can be abnormal, okay? Can be normal. So tumor markers are actually used to monitor breast cancer patients, okay, or any cancer patients. And it's not just one level that makes us do basic tests for you. We have to see a rising titer. So we find that the levels are going up and up and up. Then it alerts us to actually do some sort of screening test for you. Next slide, please. Yeah, so we've talked about mammograms, and you can see that's how they're done. And then you can pick up very clearly that white spot on the other end is a cancer. Next slide, please. Yeah, what we're actually looking for, and I don't know whether you can see it there, is all this microcalcification. And this, of course, is quite diagnostic of a pre-cancer. And so and so we always want to find it at this stage, because if it's pre-cancer, of course, we can cure you. Next slide, please. So essentially, diagnosis is by triple assessment. We will examine you, we will do some form of imaging, and then we will do a biopsy. Next slide, please. So what is the treatment of breast cancer? Next slide, please. So management and diagnosis and prognosis depends entirely on the stage of disease. And by staging, we mean what is the actual size of tumor when we first see you? What is the local involvement? Is it stuck down to the skin? Has it spread to the lymph nodes? Has it spread to other places? Next slide, please. So early breast cancer is actually a cancer that's less than 5 centimeters. So, most of the time it's because the women don't do any examinations on their own, or they haven't gone for mammograms and ultrasounds, that they come with late cancers. 5 centimeters is probably about the size of a quail's egg. So can't be that you can't feel this in the breast. It's just sometimes denial as well. Okay, so early cancers do not involve the skin or the underlying muscle. Even if they've spread to the lymph nodes, it's less than 3 or 4 lymph nodes. And of course, there's no metastasis. Next slide, please. So late breast cancer are tumors, of course, that are larger than 5 centimeters. The tumor can be involving the skin or muscle stuck down. You can see here in the picture that the nipple is retracted, and there's the big lump underneath and above the nipple. If there are many lymph nodes involved, or of course, if it has run to other places, distant sites like the lung, the bone, the brain, the liver, and any other places, ovaries sometimes, then it becomes a stage 4 and a distant metastasis. Next slide, please. So treatment involves local regional treatment, what we do to the breast and the areas around it. And this is usually surgery or radiotherapy. And then systemic treatments. We have chemotherapy, hormonal therapy, and the new kid on the block, the targeted gene therapies. Next slide, please. So how do we decide whether you go for a mastectomy or we can do breast conserving surgery, BCS? Okay, so usually for late cancers, stage 3, stage 4, you would probably end up with a mastectomy unless we try to reduce the cancer first with chemotherapy and then try to save your breast. Okay, cancers that are multifocal, more than one place, of course, you can't save the breast. Okay, sometimes if you have tumors that are right under the nipple too, it may be difficult to save the breast because remember all the ducts open up at the nipple, and therefore it means that the cancer may actually be multifocal. Okay, and of course, if there's extensive DCIs, you've got extensive pre-cancer in the background, we see that the whole breast has got microcalcification in the background, then most likely we cannot save your breast. For breast conserving surgery, usually it's for stage 1 and stage 2 breast cancers. The upper limit is usually 4 centimeters, but sometimes it's in relation to the size of the breast. Sometimes if it's 4.5 centimeters in a very large breast, we can still offer you breast conserving surgery. Okay. The thing about breast conserving surgery is that it must be combined with radiotherapy to the rest of the breast. Then and only then is the outcome similar to mastectomy. Next slide, please. Okay, so you can see here breast conserving surgery. We've done what we call a lumpectomy or a wide local excision. There's a small cut on the breast and then a tiny cut in the armpit to remove the lymph nodes. Next slide, please. Here's another example. The breast looks almost absolutely normal. And this is also after radiation, you know, the breast has come back to normal. There's a small scar, if you can see, just under the nipple there, and another tiny one in the armpit, yeah, that where we did the lymph node treatments. Next slide, please. So mastectomy, the advantage, of course, of having mastectomy is that over breast conserving is that the risk of recurrent cancer in the breast is minimalized. Although the recurrence, if you've got clear margins and you've given radiotherapy, is only 2 to 5%. Okay. Another advantage of mastectomy is that sometimes you do not have to give radiotherapy to the chest wall, unless, of course, the lymph nodes are involved. Then we still have to protect the skin over the mastectomy scar. Okay. There are different options for complete breast. You can also do this. If you do a mastectomy, you can either do an immediate reconstruction, or you can do a delayed reconstruction. So you can still reconstruct the breast for the patient at a later date. If you've, of course, removed the breast and then plan to go do a delayed reconstruction, sometimes it may be a little bit difficult to find tissue to be imported into that area, but still very, very possible. Next slide, please. So this is the scar from a mastectomy. It's across the chest wall, okay? And from this, we remove the whole breast as well as the lymph nodes under the armpit. Next slide, please. So this woman is wearing a prosthesis, an external prosthesis. That means she's wearing a silicone in the pocket in the bra. Next slide, please. So this is what we call a breast form or external prosthesis. It's worn outside the body. Can you go back, please? Back one slide. So from outside, of course, she looks absolutely normal. But when she takes off her bra, go back, please, once. That's how it will look like. Forward two, please. So other options, of course, would be a mastectomy with breast reconstruction. So you can do it, as I said, as an immediate, a one stage. At the time when you do surgery for the cancer, you can reconstruct the breast immediately, or you can do it even many years after you've had a mastectomy. And there are two methods that we do it. Either we use an implant or a silicone implant, or we can use a flap, which means the patient's own tissue. Next slide, please. So this is the simplest reconstruction. We just put an implant behind the muscle, and then the breast, you have the breast mound, yeah, okay. Next slide, please. So you can see that the mound is usually put behind the muscle, okay, and you can see that on the smaller picture that there is a scar and then just an implant put in. Next slide, please. So this lady's had a mastectomy and an implant reconstruction on the left side. You can see the mastectomy scar running down the left side, and that's a reconstructed nipple and areola tattooed in. Next slide, please. A better option, of course, is to use the patient's own tissue to make the flap, okay? And we can either use a latissimus dorsi or tram flap. Next slide, please. So latissimus dorsi means we're taking muscle, a little bit of skin and muscle from the back and making a new breast. Next slide, please. So this type of reconstruction where we take it from the back, because the muscle from the back isn't very big, you actually need to use a small implant behind the muscle to get the size correct so that it matches up with the other side. Next slide, please. So you can see the picture on the top is a lady who's had skin sparing mastectomy. That's the original skin of the breast. And then the skin where you see the circular area is actually come from the back. There's a little bit of muscle behind that and an implant behind that. And in the picture below, she's had a mastectomy, and that's latissimus dorsi with a recon nipple as well. Looks almost like as good as the other side. Next slide, please. The other option is to use the muscle and the fat from the tummy to make a new breast. And in this one, because most of us ladies have a nice little pouch on the tummy that of fat that you don't really need to use an implant. So the scar at the bottom looks like a scar from a cesarean section when you deliver, and we use the muscle and most of the fat in that area. Next slide, please. So you can see from this picture, the whole tummy has gone to make a new breast. So this is a wonderful operation because you buy one, you get one free. Not only do you get a new breast, you also get a nice tummy tuck. Yeah. Okay. Next slide, please. And this is also the breast on the right is a reconstructed breast with a tram flap, and that's a reconstructed nipple as well with the areola tattooed in. Next slide, please. So we also do nipple reconstruction. As I said, we create the nipple from the skin and then tattoo in the areola so that it looks quite like a normal nipple. Next, please. Next slide. Yeah. So even for the armpit, okay, we have gone away from doing major surgery and removing all the lymph nodes. So for early cancers, we can actually offer sentinel lymph node biopsy. This means at the time of surgery, we put a little bit of blue dye and sometimes a radioactive material near the cancer, and this will run towards the first lymph node, and that's called the sentinel lymph node. Okay, you can see that the blue dye runs up towards the lymph node, and when we open up the armpit to look for the lymph node, we send it usually for frozen section, and the pathologist can tell us there and then whether the lymph node has got cancer in it. And if it doesn't have cancer in it, then it's enough to just take out this 1 or 2 lymph nodes. You don't really need to take out many more. Okay. Of course, if the pathologist tells us that the lymph node has got cancer in it, then we will do a clearance as well, yeah, to clear all the cancer cells from the armpit. Next slide, please. So if we look at the overall survival rates of breast cancer, okay, everything depends on stage. So if you come with an early breast cancer, okay, stage 0, of course, is DCIS, the pre-cancer, and there, as I said, we can cure you, but from stage 1 to stage 4, you can see that the 5-year survival rates decrease with the increasing stage. Next slide, please. Dr. Evelyn has talked a little bit about the cancer susceptibility genes and the BRCA1 and BRCA2 genes. So I won't go much into detail with these. These are actually tumor suppressor genes, okay? And these are inherited, okay? So it's a 50-50 chance of you picking up these genes. They are varying risks, and it's difficult to calculate the risk in most of the other ones except for BRCA1 and BRCA2. Next slide, please. So you can see that BRCA1 and BRCA2, which are the most common inherited genes, account for almost 70% of all the genes that we see that cause breast cancer. And of course, you know that Angelina Jolie is a BRCA gene carrier, and Dr. Evelyn has of course talked about it in her slides. Next, please. Now, besides all that, okay, there are other gene signatures of the cancer itself. So the BRCA genes are actually your own genes, but the cancer also has genes. And according to the genetic makeup of your cancer, okay, we can now give you personalized treatments. So we look at the immunohistochemistry, and the things that we look for, of course, are the estrogen receptor, the progesterone receptor, and the HER2 gene. Next slide, please. Okay, so this is actually a picture of the genes of the breast cancer. So we look at the cancer cells and we look at the genetic makeup, and then we have subdivided it into certain types of cancer. Next slide, please. Okay, so there are basically 4 different types of cancer according to the estrogen receptor, the hormone receptor, the progesterone receptor, another hormone receptor, and the HER2 gene. So you have cancers that are ER/PR positive and HER2 negative, which we call luminal A, which are very non-aggressive cancers. They usually occur in the older women, okay? So the older women get the less aggressive cancers. And then you have luminal B, which are ER and PR positive, and sometimes HER2 positive as well, okay? So the reason we have all these different differentiations is because we have treatments for each type of differentiation that we have. And then you can have the HER2 enriched, so they are ER, PR negative and HER2 positive, or the dreaded triple negative. So triple negatives are negative for everything. The hormones are not negative, and the HER2 is also negative. And in descending order, the aggressiveness of the cancers are increasing. So triple negatives are the most aggressive. Luminal A types of cancers with the hormone positive, HER2 negative are the least aggressive, okay? Next, please. So basically, your treatment or your adjuvant therapy, surgery is still the first line of treatment. If it's operable, we will always take the cancer away. And then you have the systemic therapies, which are chemotherapy, yeah. Usually chemotherapy is given 6 times and every 3 weeks, okay? But we have many, many recipes or regimes, as we call it. And you may actually get 8 times or 16 times, depending on your type of cancer. And the drugs are usually a combination of chemotherapy agents, okay? Radiotherapy, this is usually given, it's a local regional treatment. We give it to the breast and the chest wall, and this is usually post-surgery. This is to make sure that the cancer doesn't come back, because the lymphatics actually go through the skin, and therefore sometimes we want to protect the skin, especially when the lymph nodes are positive. And then we have hormonal therapies, as I told you, for ER and PR positive cancers. We used to give it for 5 years. The present recommendation is to give the hormonal therapy for 10 years. And then you also have drug. So of these drugs, tamoxifen is the older one, and the newer ones are called aromatase inhibitors, okay? And the aromatase inhibitors are only for postmenopausal women. We also have the targeted therapies or the gene therapies or immunotherapies, and these act against the HER2 gene, but we have many, many more new ones now that are just coming into the market. Next slide, please. So even the chemotherapy has changed over the years. Before this, we used to give anthracyclines and cyclophosphamide, and the newer agents like taxanes actually have improved the survival of breast cancer in leaps and bounds, okay? They are very, very strong drugs, and surprisingly with not so many side effects, okay? Nowadays for older patients or as maintenance, we even have chemotherapy that we can give as tablets to improve your quality of life. We have many, many new agents to control the side effects of the chemotherapy. So everybody's very afraid of chemotherapy because of the side effects, okay? You know, everybody knows that you're supposed to be vomiting and you have no energy, but we now have drugs that can actually control the side effects, okay? So we have very, very good anti-emetics that, so nowadays when you do breast cancer treatments, you're not really vomiting from morning till night. You know, you may have a little bit of nausea, but that's about it. Yeah. We also have boosters. Those are drugs that we use to boost your blood cells, because when you do chemotherapy, the blood cell counts tend to fall, and that's when you really feel weak or you get anemic. So we have drugs that can boost your bone marrow to make new cells for you. We have very good pain control. And we also have drugs, as we talked earlier about Prolia, denosumab, and zoledronic acid for bone metastasis. And some of these drugs actually, if you've got cancer metastasis in the bone, you actually can use some of these drugs to build up new bone for you. Next, please. Okay, there's also many, many new hormonal therapies. We started off with tamoxifen. Tamoxifen has been in the market for almost 60 years, I think. Okay. We also have drugs like Zoladex or Leucrin that help to block the hormones at a higher level, usually for women who are premenopausal, who are still getting their periods on tamoxifen. We sometimes use these new drugs to try and stop that, because if you've got a hormone positive cancer and you're still having your periods as normal, that means your hormones are not really blocked well. And therefore, sometimes we may give these drugs for 2 years or more. But for postmenopausal women, the aromatase inhibitors are really the way to go. They are like, 4 to 5 times stronger than tamoxifen, and they're better outcomes, less numbers of recurrence and longer survival with all these drugs, any one of them, letrozole, arimidex, or aromasin. We also have injections, faslodex, and newer drugs that actually help to boost the action of the hormone therapy, like PARP inhibitors, mTOR blocks, and everolimus. So all these drugs are now, we keep getting newer and newer drugs because the targets are so many in breast cancer that we can use different combinations to give you better outcome with good quality of life. Next slide, please. So with the targeted therapies, the older one is called Herceptin or trastuzumab, okay, and these are actually monoclonal antibodies to the HER2 gene. So they actually go and block the gene, and therefore the cancer cannot grow. So we have many, many newer ones. We have pertuzumab, lapatinib, we have TDM1. This is the Herceptin, which is attached to a chemotherapy drug. So a little bit more effective. The TDMI1, Afinitor, which is a mTOR blocker that is used in combination. So PARP inhibitors. So you've got a whole new group of therapies that are now up and coming. Okay, unfortunately, they're also very, very expensive. Herceptin alone can cost you almost 100,000, 100 to 150,000 a month, just for using. For the whole year for using these drugs. Yeah, some of the CD4K inhibitors like palbociclib, it's like 5,000 or 6,000 a month. So you have to have very, very deep pockets to do these targeted therapies. But the outcomes, if you can afford them, the outcomes are actually very, very good and added on, which gives you very, very good quality of life as well. Next, please. Okay, so even with radiotherapy, we now have better methods of giving radiotherapy. The original one was giving just external beam, and the newer one is image guided radiotherapy. But the new kid on the block is intraoperative radiotherapy. That's just a single dose. So usually radiotherapy is in 15 to 20 fractions. It means you have to come every day for about 10 or 15 minutes to do your radiotherapy. Monday to Friday, weekends you rest. So, and to a total of about 20 times, so 20 days, 15 to 20 days. But now we can actually give you intraoperative. That means at the time of surgery, we can give you just a single dose of radiotherapy, and that will suffice. That will be more than enough, and you don't need to do the everyday treatments. Next slide, please. This is called intraoperative radiotherapy. Radiotherapy applied to the tumor bed at the time of surgery. So you can see during surgery, there's a cavity there. So the radiotherapy machine is put into that cavity, and the radiotherapy is delivered just at one dose. Okay, and these machines are all available both in the government hospitals. I think in University Hospital it's available. Where I work in Pantai, we also have this. I think Subang Jaya has also got this machine. So it makes a lot of difference for patients who are living far away from the hospitals or from the East Coast or from East Malaysia, because you don't have to travel every day to get your radiotherapy. You can actually have it at the time of surgery. Next, please. So with breast cancer treatments, they've become so advanced that we can now personalize the treatments for you depending on the immunohistochemistry or the face of your cancer. Yeah, you have better prognosis. Most of our women are doing very well and living much longer with better quality of life and better control of the cancer. So breast cancer is not really a death sentence. The key here is to detect it early. Thank you. Yes. So we could take questions now.
First of all, thank you for the talk. Her question is on calcium and vitamin D consumption. She says she's taking calcium supplement with a low dose of vitamin D. So does she take the calcium and vitamin D at the same time of the day, or can she take it separately but on the same day?
No difference at all. Just take the calcium. It's best, of course, if you take it together, because the vitamin D is important for absorbing the calcium from the intestine. But, you know, if you go out for a morning walk, you're still getting your vitamin D. Our body has vitamin D stores in the liver. So you could still take it at separate times and still have your vitamin D doing its job of absorbing the calcium from your intestine.
Okay, a stage 4 HER2 cancer patient is on targeted chemotherapy, and the doctor says she needs a lifetime chemotherapy, which is extremely costly. She is on Herceptin and Perjeta.
Correct. So the latest research shows us that the combination of Herceptin and Perjeta, okay, actually give a better outcome for patients who have the HER2 gene in their cancers. That means the survival rate is a bit longer, and the recurrence is also less. And we're very lucky that both these drugs are made by Roche, by the company Roche, and they have a very good bonusing project in which if you pay for the Perjeta, you actually get the Herceptin free. So you get the combination of drugs for the price of one. But it's very important that if you have a HER2 positive gene and she's stage 4, the unfortunate thing is that you actually need to continue on these treatments until progression. That means it's going to be a very, very expensive journey, because usually they will give you Herceptin Perjeta for a year and then probably drop off the Perjeta and you just do Herceptin as maintenance. But yeah, this is what will keep the cancer under control.
And thank you very much, doctors. Yeah, thank you. Very, very informative. Yeah. I would like to ask a question. Myself, I am 45 years old. ER/PR positive. Yeah, stage 2A.
Right.
And I had left mastectomy
Okay.
and premenopause. So I am on tamoxifen for almost 9 months.
Right.
And last month, during my review with my oncologist, because I have a sign of my period coming back, so yeah, so my oncologist has advised me to have the jab. I think it's Rucrin.
Yes, correct.
Yeah,
So
yeah,
the choice would be between Leucrin and Zoladex, and Leucrin is always a little bit better because the needle is smaller.
All right, I see. Yeah, okay, it's not painful at all. Yeah, and yeah, but when I get the advice from my breast surgeon, he actually has suggested that I should go for a removal of my ovary and uterus instead of taking this Rucrin. It's a long-term solution.
Yeah. So usually what we will do, sorry, how young are you again?
45.
Okay. Yeah. So at 45, okay, normally what we would do is when we start tamoxifen, we would look at your periods and see. Now, the best case scenario is that if your periods don't come back at all, okay, because that means we are blocking the hormones very well. If your periods come back, but they are irregular, they come for 1 month and then 2-3 months they don't come, that's still fine, okay? But if they come back every month on time, that's when you need to block it a little higher up. So it would either be Leucrin or Zoladex, as you're doing, as you was suggested to you. But the reason why we give you the injections rather than doing oophorectomy is because the injection is reversible. I mean, you stop the injection, your period may come back. Okay, so
Right.
you know, it's a choice for you to make, because you may not really be menopausal yet. Okay, so at 45, most women get their menopause at around 50, 51, 52. So at 45, after if you've taken the hormone therapy for about 5 years, you know, you're not really menopause. We don't want to push you fully into menopause, because the symptoms of menopause itself can drive you crazy. Okay, so
Okay.
so what we do is we try something that's reversible first. Okay, that's not, you know, it's not, if you remove your ovaries, that's it, 100% your menopause. So looking at your disease, you've got 2A, which is actually early cancer, no lymph nodes involved. You know, you've done a mastectomy, you're on the tamoxifen. You know, I would say try the leucrin for 2 years first. Okay, and then slowly maybe wean off. You know, the thing is, when you're on the leucrin, you also need to follow up with your gynae, because you can get cysts in the ovary. Okay,
Oh,
so
okay.
yeah, so look at how you go over the next 2 years. And then as you come closer towards 50, if you decide you want to have an oophorectomy at that time, you know, do a blood test first and see if you are already menopause, well and good. If you're not, then that might be an option. Okay. Now, if you, for example, had, you know, more a higher stage, if you were a 3A and you had many lymph nodes, or you know, you had stage 4, of course I would tell you go for oophorectomy, because you know, removing the ovaries is a treatment in itself.
All right. I
Okay.
see. Okay. May I add on with one of my actually during my quarterly review where I take blood tests, my CEA level is hovering around 7 to 9. It goes up and down, up and down. So I'm not too sure whether this is concerning.
I'm not impressed. I'm sorry. Listen, the CEA values, number one, they're not diagnostic. Okay, they don't tell you anything. CEA is actually more for colon cancer. Okay? But if you had cancer, or you had colon cancer, something, it'll be in the hundreds and thousands. It won't be just 5 or 7. You know, so
Okay.
really, I mean, it's not that important. I would advise you to just have your regular blood tests when you do, and if you really see very high levels of CEA, it just alerts your surgeon or your oncologist to do a scan for you. That's it. Probably a CT scan or a PET scan.
Okay, thank you very much, doctor.
Okay, Pat, some questions on food now. Does consuming MSG, hawker food, restaurant food cause recurrence of breast cancer? Can consumption of red meat like mutton and pork increase the chance of recurrence? All related to food.
Okay, and the answer to all is no. Eat what you like. Okay. Now, the reason I'm saying this is we everything we tell you comes from scientific evidence. That means we know that you know, things have been examined. We've done clinical trials, and then we tell you what we tell you. Now, with all the food, the only thing we know that can cause carcinogens are chemicals that can make your cells become cancer. Okay, so carcinogens, the only thing we know so far is burnt animal fat. So try as far as possible not to eat too much of grilled food. I mean, actually, Asian diet is very, very healthy. We don't eat chunks of meat. Okay, we don't burn our meat. So, you know, our diet is actually very good. So just take a little bit of precaution and cut down the fat in your meat. Okay, so when you're going to cook your meat, make sure you take away all the fat. Okay, for the Chinese girls, not so much of siu yok and cha siu. Okay, you can still take it, of course, but not so much. Like, you know, just everything in moderation, please. That's it. Middle path, best.
I hope everybody is going to listen to us, because they prefer to listen to us on the internet, and everything is like taboo, and they'll end up drinking water.
I know. All this talk about sugar causes cancer. Yeah. It's all somebody's coming out of somebody's hat. There's no scientific proof at all. The thing about dairy products also, again, of course, if you're going to take dairy products, that's animal fat, remember, try and drink low-fat milk instead of, the nice full cream milk. But even if you do once in a while, nothing's going to happen, really.
And I think if you add it just to your coffee, it's not a lot of milk.
Exactly.
So it's a very small amount. Okay, there doesn't seem to be any more questions. So if I may, I will ask you a question on this, the cancer, the genetic stuff about the cancer itself. I think people are pretty confused. Everybody knows about ERPR and HER2, but what about all these MIB1s and the Ki67s? What role do they play? Because it's very expensive and some women are getting it done.
Okay, so the Ki67 and the MIB are actually proliferative index. So it basically tells us how fast your cancer is growing, how aggressive your cancer is growing. It's usually a score, okay, say from 0 to 100%. So if you had a low Ki67, so usually you'll find that the luminal A cancers, the ones that are ER/PR positive, HER2 negative, will have a Ki67 of less than 20 or 30%. That means they're not growing very fast. Whereas a triple negative breast cancer will probably have a Ki67 of 60, 70, sometimes even 90%. So it gives the oncologist and the breast surgeon a little bit of more information about the types of chemotherapy that we want to give you and the number of times we want to give you. That means, can we hold back the really, really strong chemo, or do you need everything up front?
I had my right mastectomy done about 9 months ago, and I'm stage 2A. I'm ER positive for estrogen and progesterone, and then on letrozole. I've been taking letrozole for about 8 months now. My question is, I have this stiffness of my fingers, especially at night when I sleep. I feel that it's very stiff, and when I roll to one side, when I change my movement, it seems to be getting better. And in the morning when I wake up, the stiffness is there, but once I walk around, it seems to be settling down. So I don't know what is the cause of it. Is it the side effects of letrozole?
Yes, it is, my dear. Letrozole causes osteoporosis. It causes musculoskeletal pain, okay? So essentially what you actually have to do, so when you look at the benefits of the drug versus the side effects, the benefits far outweigh the side effects. So the side effects are, you can get muscle pain, you can get stiffness of the joint. And the only thing I can tell you that if you don't use it, you will lose it. So you need to move, you need to do exercises. Yes, you need to do exercises. You need to walk so that joints and your muscles and your bones remain supple and strong. And of course,
okay,
vitamin D. Yes.
Vitamin, yeah. Okay. The other thing also, I was put on vitamin D, calcium, and I'm also taking glucosamine, mitriptyline, and fish oil.
Glucose, the calcium and the vitamin D are for the bones. The glucosamine is for the joint.
Yeah, the knee joints and all that. And I take also fish oil. Is that too much? Am I taking too much?
No, fine. It's absolutely fine. Although I would rather eat the fish than swallow the fish oil.
Yes.
Okay.
Yes.
Okay. The other thing, it's the side effects of this joint pain. Is it arthritis?
No, it's what we call osteoarthritis, which is an enhanced aging.
Sorry, I can't hear you.
It's an enhanced aging of the bones. Your bones are older than you.
Oh, but it's not rheumatoid arthritis and things like that, is it?
Rheumatoid arthritis, usually when you do your blood test, your Rh factor will be positive. Your rheumatoid factor will be positive.
Oh,
and that's a different ball game altogether.
So so that means it's just a part of the side effects.
Yes.
And why is it when I move it gets better? I don't understand. Because
if you don't use it, you will lose it. So you have to keep moving your joint. The minute you wake up in the morning, start moving. Then you won't have any pain. See, the way to look at it is this, okay? One of my friends told me, okay, after 50 years old, if you wake up and nothing hurts, you're dead.
Oh.
So something must hurt, then you know you're alive.
All right. And also, I think that because of the pain I get, that means the letrozole is working. Is that what it is?
Yes.
Okay, thank you so much. I was
Okay,
just worried.
just a little bit on that
Yeah.
too. It's
Yeah.
very important that when you get up, you need to move all your joints before you get out. So the treatment for osteoarthritis is actually gradual, graduated, gentle exercise. You must not stop moving. For example, you have shoulder pain, you stop moving it, you get a frozen shoulder. So that's a very good example. So you need to gently do it. The other thing is I've been working with a few patients who have very severe peripheral neuropathy with some of their drugs. And so the oncologist that are working with them says that you have to have a very good, nutritious, proteinaceous diet. Without protein in your diet, your side effect for peripheral neuropathy is so bad that they can't hold even their handphone. It's so painful. So these are some of the things that most of you are saying, don't eat meat, don't eat that.
Yeah, correct.
Drink only plain water. Then your side effects are going to be much more magnified.
Okay.
Now, 49-year-old lady, triple negative, second year in remission. Her full treatment finished in October 2018. Now she finds a fibroid in the uterus, and her period came back for 2 months in March and April 2020. Then it's completely stopped for now. The OBGYN advised to remove, and she wants your opinion on whether she should.
And the size of the fibroid? What's the size of the fibroid?
Maybe 3 cm? Yeah, that's small.
Forget about it.
Forget about it.
You don't need to do anything. Just wait for your menopause.
Yeah, it's too small to do anything. Yeah. So the next question, who should they see for their follow-up? Do they see the oncologist? Do they see the breast surgeon? Do they see both?
See both. It's always better when more eyes are looking at you. So you make the appointment such that the appointment silang la. One you see the oncologist, then 6 months later you see. So it depends. In your first 5 years, it's good if every 3 months somebody sees you la. So you see the oncologist. 3 months later you see the breast surgeon. 3 months later you see your oncologist. So actually you're seeing them once in 6 months. Once you cross 5 years, then you push it to 6 months, so that you're seeing somebody at least every 6 months, but you're seeing that one person every 1 year. Once you cross 10 years, then you can do it once every 2 years. That means once a year you see one doctor, something like that.
Which means I have to set the appointment myself, right? Even though the clinic actually set it up for me.
No, you tell the doctor, when you see the doctor, you tell the doctor, listen, I've just seen you. I'm only going to see you after 6 months. In between, I will go and see my oncologist. Something like that. La.
Okay, got it. Thank you.
Welcome.
I'm actually Dr. Pat existing cancer patient. I shall see her in next 2 weeks. Hi, Dr. Pat.
Yes, hello.
I have a question here. I finished my chemotherapy and also the radiotherapy.
Right.
I was told that, from one of the friends, she's actually my existing facial lady.
Okay.
She refused to do facial for me, unfortunately. She said, I've just finished my radiotherapy and she's still not comfortable with that. So that actually scares me a little bit, that because after radiotherapy, I actually come back and stay with family, hug my niece and all that. Is there a problem?
No, of course not. Change your facial lady. Find a better one. The radiotherapy was nowhere near your face, okay? It was only on the breast and the and maybe the armpit. Even the armpit nowadays we don't give. So yeah, so just change your facial lady, find a better one.
All right, okay.
Yeah,
and
know
after
that.
my radiotherapy, I come back and I hug my mom, my niece and all that. Is there a concern? Is there a problem?
No, it is not contagious. It doesn't, this is different. The radiotherapy is at the time when you have it.
Okay.
The minute you walk out of the room, there is no side effect.
Right. Okay.
So it's different.
Radiotherapy
is very different.
It's not a radioactive substance.
Yeah, it's not radioactive. It's not like a PET, or you do a bone scan and all that, where they may have, or you do a thyroid, radionuclide thyroid scan is different, because the radioactive material stays in your body for a short while, even though for the PET it's about 4 hours for the half-life. So it actually all goes out in your urine quite quickly. But it's the same. People ask me the same thing. After my X-ray, is it safe for me to walk around? There's the same question. There are two different things. Remember, I said that each human being emits about 7,000 becquerels if you are 70 kilograms. That is actually emitting low doses of radioactivity. So your facial lady is emitting radioactivity. But your X-rays, your radiation therapy are two different things. It just acts on you and that's it. And it's gone. It passes through you. In the case of diagnostic, it doesn't treat you at all. It's low dose. And for radiation therapy is to kill yourself. So there is no radioactivity, unlike a radionuclide bone scan or a PET scan. They are different. They actually inject a radioactive chemical into you, but they all have very short half-lives, so that when the time you leave, they will let you know whether it's safe. If you have a radioiodine for thyroid ablation, it's different. They will tell you after so many days only you will hug your children. That is a totally different thing. This is something that everybody gets mixed up on.
Right. Thank you. Thank you very much for that. And then even the CT scan, I do not have any issues with like coming back and staying with family, right?
Yeah, I told you, the dose is different. I'm using X-ray to look at things. I'm not using X-ray to treat you. Yeah.
Okay. Right. Thank you very much, doctors.
Welcome, welcome.
I'm still having numbness in my feet and once a while needle pain in my legs. Are these normal side effects due to chemotherapy?
Some of the chemotherapy does cause peripheral neuritis. Okay, that means it affects the nerves right at the end. That means the ending part of the nerve. So in your fingers and toes, of course, you can get it on the sole of the foot. Okay. Sometimes vitamin B complex, so B1 and B6, it's a combination called neurobion, can sometimes help you, but it usually gets better with time. But if you have diabetes or you have other problems, this can be a permanent feature.
And don't forget your protein in your diet, please. From meat, not from tofu. There are different types of protein. It has definitely helped women with this. They can much better than neuropathy. Another question for you, Pat. I had mastectomy in February 2020. The doctors removed 38 lymph nodes. And to date, her wound still hurts. Is that normal?
Okay. I don't know what the size of your cancer was, but 38 lymph nodes. Usually when we do axillary clearance, that's the operation to remove the lymph nodes. We actually follow the anatomy. Okay. Now, it's different for different people. You can have as few as 4 lymph nodes. You can have as many as 50. 38 would actually be a lot for me. So we normally do what we call a level 1, level 2 clearance. We don't touch the lymph nodes that are further up. But some of the older surgeons do. They still do what we call a radical mastectomy. And a radical mastectomy involves taking out all the lymph nodes, including those up to level 3. And that, unfortunately, can sometimes in the long term lead to swelling of the arm. I mean, it won't happen now. It may happen maybe 10 years down the line. So, you have to be a little bit careful. Be a little bit careful with that particular arm. Try not to lift very heavy things on that side. I would say 5 to 10 kgs would be max. I think I also can't lift 10 kgs. But anyway, yeah. but yeah. Be very careful, especially if you're doing gardening and stuff like that, wear gloves, because if you get an infection on that side, very quickly, it can become lymphangitis and it can give you lots of problems, and it can enhance or quicken the effect of lymphedema or swelling of the hand. But actually, if you're one of those women who has more than 50 lymph nodes, then you most probably won't miss 38. So don't worry too much about it. Just be a little bit careful with that arm.
Thank you to Pat for doing this. And I just need to just round it up, and thank you everybody for attending. Thank you, Pat. Sorry about the technical problems. Thank you, Marian and Pavi, who are sitting in the background helping to get this going. And thank you to Pfizer for supporting this series of online symposia as well. So I think we need to come to a close. If there are any more questions, please post it to Marian and we will try to either answer it by email, or we may organize another webinar to answer these questions. Am I right, Pat? You'll be fine coming back?
Yes, definitely.
Yes.
Thank you so much for hosting, Evelyn, and for the good talk as well.
All right. Okay. Bye-bye, everybody.
Hey, thank you,
Doctor.
Thank
Thank
you.
you.
Bye.
Thank you.
Thank you, doctor.
Thank you.